This is a brief overview of basic trauma concepts and related nursing care. We will be learning about different categories of trauma and the priorities of care for the trauma patient. So what is trauma when we're talking about care of the quote-unquote trauma patient? Well, in these cases, trauma refers to a situation that was disturbing or caused some type of physical injury. Trauma can be caused by a car accident, a fall, an assault, an explosion, and we categorize trauma into larger categories. So, for example, penetrating trauma refers to something that has broken the skin and entered into a cavity or an extremity or another structure. So we're talking about, with penetrating trauma, anything from a stabbing to falling on a sharp object to a dog bite or a gunshot wound. And then we have blunt force trauma, and that relates to an application of force. So think about your patient being hit or even a compression occurring. Some examples are more obvious, so like a patient who's been hit by a baseball bat, for instance, and others are less obvious. So you can have blunt force trauma occurring due to acceleration and deceleration. So think about being thrown into a steering wheel after hitting a telephone pole. Other types of blunt force trauma include crush injuries, so someone who's been trapped under machinery, let's say, or someone who fell or they struck an object like punching a wall. And then we have blast injuries. This is actually technically a type of blunt force trauma, but these are very specific because they include blunt force and sometimes penetration trauma as well. Think about someone who's been close to an explosion. So the force of that explosion will actually cause an injury itself, but that explosion might throw that person into a wall, and there we have further blunt force trauma. And what if that wall had a pole sticking out or some other object sticking out of it that penetrated? Well, now we have a penetrating trauma as well. So it's common that in more severe or complex types of trauma, patients will have penetrating and blunt trauma and even blast trauma in specific cases. Nursing care of the trauma patient should really bring us back to our basic emergency priorities, and that brings us to the primary survey. So some nurses will encounter a patient at the scene or after the traumatic event has just happened, while other nurses may be caring for a trauma patient after they've been admitted to the hospital. Now, what we're looking at in this slide is the priorities of care basically on the scene or after a traumatic event. And that's where we see the primary survey. Now, before conducting a primary survey, the nurse should always assess if the scene itself is safe. This is essential. The nurse will do the patient no good at all if he or she becomes a victim too. So, once arriving safe on the scene, the nurse would immediately conduct a primary survey. And this starts with asking if their airway is patent. Is there something in the airway? Are they just unconscious and they're not able to keep that airway patent? So in the case that the airway is compromised, the nurse would perform a jaw thrust. And notice this is different than what you may have heard in your CPR courses, for instance, that head tilt chin lift. Because you can see here, along with airway being compromised and along with assessing airway, we're stabilizing their cervical spine. So we don't want to extend their neck with that head tilt chin lift. We're taking their cervical spine out of alignment if we do a head tilt chin lift. And do we know if they've injured their cervical spine? Not officially right at the scene, especially if we didn't witness the event. But if we can't rule out a possibility of a cervical spine injury, we need to take measures to protect their C-spine and hold their head and neck in alignment. So that's where that jaw thrust comes in. Now, following airway is breathing and circulation, and these should be concepts for review. It's really important, though, to recognize that once on the scene, after, let's say, a car accident or after some traumatic event, the nurse needs to assess for these ABCs immediately instead of getting overwhelmed with the potentially gruesome or dramatic or really distracting scene. We need to bring ourselves back to these ABCs. And the ABCs can be assessed very generally if our patient can speak. So think about that. They have an airway if they can speak. They're breathing because they can produce airflow through their vocal cords to make words so they can speak. And they have some sort of circulation to their brain because they're getting blood there and they're able to form words and move muscles. However, this doesn't tell us everything. It doesn't tell us whether the patient is hemorrhaging or if they're about to lose consciousness. So we need to do a little bit more of an in-depth assessment. So what else is involved in this very efficient primary survey when we hit breathing? Well, we look at positioning of the trachea. We want to assess whether that trachea is midline. And you can see here someone's assessing that with their 3 fingers. So why is this important? Well, a trachea that is not midline indicates that there could be an intrathoracic abnormality, that the trachea is essentially getting pushed by forces inside the chest or pulled by forces inside the chest. So think of it this way. The trachea is getting pushed because something on one side of the chest is pushing the lungs the other way, and the trachea kind of gets pushed along with it. Or the trachea is almost getting sucked to one side where the problem is, or getting pulled. And in that case, the problem is almost creating a vacuum and pulling the trachea toward the problem. So you can see in this picture that the trachea moves away from a problem when that problem produces high pressure, something like a severe pleural effusion, or something that produces very dangerously high pressure like a tension pneumothorax. And a tension pneumothorax is where someone has very high external pressure causing a collapsed lung on one side. And on that same side, there's continued pressure that's now also pushing on the heart. And this is deadly if nothing is done about it. So you can see the trachea is being pushed away by the affected lung. So if the affected lung is pushing it, it's going toward the healthy lung. But in other cases, the trachea is deviated or pulled toward the problem, toward the affected lung. And this is when the problem is a low pressure problem. So it's no longer pushing, it's pulling. So think of it as sucking the trachea out of midline like a vacuum. Now these low pressure cases include an open pneumothorax, a poorly or underdeveloped lung, and we might even see this chronically in people, for instance, those who have had one lung removed. But essentially, we're looking to see if the trachea is midline and for other signs of breathing issues as well. So is their chest rising? Is it just rising on one side? Do they appear hypoxic? So are they losing consciousness? Are they pale? Do they look like they're struggling to breathe? This sounds like a long list, but it can actually be assessed pretty quickly just by looking at that patient. As we consider what's involved in assessing the C of the ABCs, you should really already know this. Check a pulse. And if your patient's alert and talking, you know they have a pulse. But checking it still and assessing the nature of that pulse can really give you cues about if there's a circulation problem. So are they tachycardic? Is their pulse thready? That could be a sign of hypovolemia or shock. And what other many signs of hypoperfusion are there? So think about what happens when our organs don't get enough blood. So for instance, with the brain, these patients may look restless or confused or even unconscious. And what's the patient's blood pressure? If you see tachycardia and hypotension, those are cardinal signs of hypovolemia. Do their limbs look pale? Do you see bleeding? Is it internal, or you can even see some retroperitoneal bleeding, or is it external? So all of these components really relate to circulation. Now with trauma patients during this primary survey, we don't stop at ABC. We also look at D and E, disability and exposure. So let's say you approach a patient who obviously has a patent airway, they're breathing normally, they're talking to you, they have a strong pulse, they're just a little anxious after an accident. So do you stop your assessment? No. We've determined that the ABCs are addressed, but what if their adrenaline response to this accident is preventing them from feeling a femur fracture or a potential amputation? Or what if the ABCs check out and they're reporting intense chest pain? So this could be a sign of something ominous occurring that appears to just be pain for now, but could become really seriously life-threatening of an issue later. So therefore, we take pain seriously as we also assess if there are any obvious signs of disability by conducting a more thorough neuro assessment. And this typically consists of the Glasgow Coma Scale. So part of this D, this disability assessment, involves our E, exposure. In order to do that thorough assessment, we need to see our whole patient. So remember, whether they may or may not be willing to tell you everything that's going on, we need to assess it. Your patients cannot always tell you everything that has gone wrong. Therefore, you need to see underneath them, and you need to observe any covered areas to ensure that there aren't any hidden injuries. So don't forget to protect the cervical spine and log roll these patients as you assess for further injuries during that exposure period. Also, traumatic events often occur in public places or in broad daylight, So don't forget to do what is ever feasible to maintain the patient's dignity and keep them warm as you expose them to assess the extent of their injuries. So let's take a quick look at a couple of examples of what we've talked about. So this x-ray here on the left shows a tension pneumothorax. Remember, black on an x-ray is air and white is stuff. Depending on how bright white it is, it's more dense, and more cloudy white is less dense stuff. So this patient is lying face up, and that big black area in their left lung is from a pneumothorax. So air has somehow gotten between the lung, the outside of the lung, and the chest wall, and pushed the lung to the point of collapse. So this can happen with a gunshot wound, a stab wound. We even see spontaneous pneumothoraces. So what else do you see here? You see a big collapsed lung, but the heart, that little cloud that's in kind of near the center of their chest, is being pushed to the patient's right side. The heart's supposed to be on the left side. So what happened? Well, this pneumothorax is creating so much pressure that it's not only pushing on the lung and collapsing the lung, but it's now pushing on the heart and compressing the heart. So this is what a tension pneumothorax could look like on a chest x-ray. Now, the treatment is immediate decompression of that left lung so that everything can be re-expanded. And typically, this is done by a trained member of the trauma team. So on the right, you can see a patient with a deviated trachea. However, notice that this man is on a nasal cannula. That leads me to believe he is not suffering from a tension pneumothorax or some other acute injury, but maybe he's had his left lung removed due to either lung cancer or even pulmonary fibrosis. But it's pretty rare that you can see an actual example of tracheal deviation, so I wanted to include this one here. So take a look at this case study. You're leaving clinicals, you're tired, ready to go home, and you're walking past a construction site, and one of the workers out there calls out to you and says, "Hey, are you a nurse?" Because you're wearing scrubs, he just left clinical. And he tells you that his buddy just fell off of a 2-story platform and he needs help. So you decide that this is your moment and that you understand the basics of trauma care, so you run to check out what's going on. Take a minute to think about what you would do upon arriving to this scene. Pause the presentation and actually pause it and think about what you would actually do and make a quick list, and then restart the presentation. So remember, the most important thing to do upon arriving to the scene, especially if the traumatic event has just happened, is safety. If he fell from a construction site, what else might go wrong? Was something not secured up there and therefore now you're at risk for, or someone else is at risk for falling? Are there electrical wires or other hazards nearby? You need to ensure that this scene is safe before you even enter it. And as you're assessing the scene, a 911 call is warranted. This man has just fallen 2 stories. Even if, when you eventually see him, he appears to be completely stable, there could still be internal damage from such a long fall that needs to be assessed. Now, beginning with your ABCs, you've determined everything's safe, you approach the patient, you would assess his airway. Is he moaning or is he silent? If he's moaning, that immediately tells you a lot of information. He has a pulse. He has some sort of airway. But you don't know if that airway is sufficient. He could be moaning through a really bad airway. So when you approach the patient, you're going to hold C-spine and instruct your classmates, who fortunately have come along with you and learned this content as well. Your classmates are going to assess his airway, his breathing, and his circulation as you hold C-spine, or vice versa. They're checking for pulses. You're seeing if he can talk or if he's unconscious. And soon is going to arrive D and E in our primary survey. So again, a neuro assessment can tell us about any neurological compromise. It can also tell us a lot about our ABCs. If he can talk and hold a conversation with you, that tells you he's getting blood flow to his brain. Examining his arms and legs, his torso, it can tell you a lot about if there's any obvious deformities. So in order to expose the patient, you would need to instruct maybe the other construction workers to look for some kind of blanket or a tarp or whatever they have nearby to cover the patient as you and your classmates examine him for any obvious deformities or bleeding. So you can see that this is a non-clinical setting. This assessment becomes more complex in terms of liability and your roles, and you also need to get permission to approach this patient if they're conscious. So plus in this scenario, you're actually nursing students, but if we pretended you were nurses and you were approaching the patient and you have a broader scope, you could talk with this patient and say, "Hi, I'm a nurse. Is it okay if I take a look at you?" If he says no, if he says, "I'm fine, don't touch me, I'm fine, leave me alone," then he has the right to refuse care, just like any patient in the hospital has the right to refuse care. You need to ask permission, though, if he's conscious. Now, you may think, well, we just called 911 and maybe he doesn't want us to call 911. He has the right to refuse care from any EMS providers that arrive as well. So it's okay to call 911 if he hasn't asked you to call 911. So you called 911, he's refusing care, you just have to wait now. You can keep an eye on him, and if he loses consciousness, then you're allowed to start CPR, etc. But if he is conscious and he refuses care, he has the right to refuse care. So just keep that in the back of your mind. To keep things simple, in this case, we're assuming he is conscious and he is okay with you looking at his deformities or any other assessment that you needed to do. So take a look at this next case study. This is another example of a trauma case. So we have a 28-year-old male who called EMS after being poked in the eye with an unknown object while just laying in his pool. 3 witnesses were there and no one could explain to EMS exactly what happened. So think about what you might prioritize and what do we already know about this patient with just this little amount of information. So let's pretend this patient has now arrived to the trauma bay and you are the trauma nurse. You see a 3-foot long small plastic pipe sticking out of his left eye and he tells you he can't see. Take a minute to look at these questions and consider what you know and what you need to do for this patient. Pause the presentation and then restart to check your answer. So we already know that this patient has an airway. We already know that this patient has a pulse and that his neuro status is fairly intact because he could report what happened. So this already tells us that we have some of these boxes of the primary survey already checked. Now, what do you need to think about? Let's say this patient comes into the trauma bay and you are working and you need to prioritize his care. Well, you know right now that he has an airway, but you would still want to assess this and make sure that there's no other compromise. Just because the sharp object went into his eye doesn't mean that there isn't other sharp objects or something else that is compromised that maybe he wasn't even thinking about because he just had something poke him in the eye. So it might distract him from something else that's going on. If that's not the case, we're still assessing our breathing and checking his blood pressure. There could have been some kind of hemorrhagic trauma, so we are assessing for hypovolemic shock. And as we look through that, remember we have D and E, so we're looking at his neurologic assessment, digging a little bit deeper into how his neurostatus is. So he could report to us that something happened, but what else can he tell us? Let's dig a little bit deeper and see how his neurological assessment is. And then with E, remember, we're also looking for other type of damage that could have been done. Just because we are focusing on this one specific traumatic event, is there something else that happened along with this event that we're maybe being distracted by because of the trauma that he reported?